Hello, everyone, and Happy New Year. Thank you so much for joining us today. My name is Jonathan Heller, and I'm delighted to welcome all of you to the third of our 4 webinars on advancing health equity in health departments. I'm coming to you again from our offices in Oakland, California. I'll be the moderator and facilitator for today's call, and I'll also provide a brief overview of the Health Equity Guide, the resource Human Impact Partners released in July last year that inspired this webinar series. I'll start by telling you who's hosting today, then I'll do a bit of housekeeping, and then we'll dive into the presentations. This webinar series is co-sponsored by our amazing colleagues at the Government Alliance on Race and Equity, aka GARE, the National Collaborative for Health Equity, and the Health Equity and Social Justice Committee of NACCHO. We really appreciate all their contributions to this work. Our goal is to highlight inspiring examples of health departments that are transforming the way public health does its work to focus more explicitly on racial and health equity, and to provide concrete tips to others who want to do the same. As I mentioned, this is a 4-part webinar series. Each webinar focuses on a different component of the Health Equity Guide. If you haven't heard them already, you can watch the recordings of our November and December webinars about building internal infrastructure at health departments and about working across government by visiting the website healthequityguide.org. Today, our focus will be on fostering community partnerships to advance health equity. But first, a bit of housekeeping. We are recording today's session, and we will share the recording and the presentation slides for all the registered participants. For folks on social media, we're also going to be live tweeting the hour using the hashtag #BuildPowerForEquity. You can see it there in the middle of the screen. We encourage you to add your key takeaways using that hashtag #BuildPowerForHealthEquity too. So today's webinar is going to be in listen-only mode. That means that you can hear us, but we can't hear you. But that doesn't mean that it won't be interactive. We'll have at least 15 minutes at the end for Q&A, and we encourage you to type your questions at any time into the Q&A panel, and we'll use those as the basis for the discussion at the end. The Q&A panel is located on the right side of your screen. It can be toggled on and off by clicking the Q&A icon that you'll see on the top right of your screen, or on a Mac, it's on the bottom right of your screen. Before submitting your questions, make sure all panelists is selected. And you can use the Q&A panel also to let us know if you're having any technical problems. For those of you on the last webinar, you may remember that we did an additional Q&A period at the end of the official close of the webinar for another 15 minutes. That worked well, so we're going to do it again. So for 15 minutes after we officially close the webinar, if you're interested, you can stay on the call and have additional questions answered by the speakers, similar to a way you would do that at a conference. So if you can, please stay on the call until 11:15 Pacific to have additional Q&A. So our objectives for today are to describe why fostering community partnerships is key to advancing health equity, and to highlight how Alameda County engages in social justice movements to advance health equity and racial equity, how Kansas City shares power and space with community organizers to change policy, and how NACCHO is supporting building community alliances to advance equity. And last, we want to showcase the Health Equity Guide and other resources to help your health department foster community partnerships. We have a fantastic lineup of speakers today. I'll do brief introductions before each presentation, but thank you so much and welcome to Sandy Galvez, Rex Archer, and Yvonne Thomas-Smith. So we want to bring you all into this conversation now, and are doing a couple polls now, and we'll do a couple polls later to get a sense of who's with us today and what your perspectives are. Please note that the poll will be on the right-hand side of your screen, and you may need to scroll down for both polls if you can't see all the options that are listed. And then please make sure to press the submit button once you've answered the questions. So first, please let us know what type of organization you're primarily affiliated with. We know folks might have multiple affiliations, but please pick the one that is strongest for you. And second, please let us know how many people are in the room with you as you watch this webinar. We asked this question because on the first 2 webinars, there were a number of people who told us they were watching in groups. On our last call, roughly 200 of the over 700 participants watched the webinar with one or more people. So we're curious, how many people are you watching with at this time? And we want to acknowledge again that the recordings of the webinar are going to be available following the event in case you want to share this webinar with colleagues or if you miss anything. I'll show the results in a moment so we can all see them. So go ahead and fill in your answers. Okay, now let's take a look at the results. It's going to take a minute to pull them up, but go ahead and press the submit button if you haven't already, and we can close the poll down. As we wait for the results, let me say that we know that there are a bunch of options listed, but we're really interested in getting a sense of who's with us and what institutions you're at. We know from the registration information that there are people registered from all across the U.S. and people working in small rural areas and suburban areas and large metro areas, and we even have folks from Australia, Canada, and Nigeria who registered. And because we know that folks are in such different environments, we also designed the Health Equity Guide that way, providing a range of strategies that folks can use to get started no matter where you are on the health equity ladder. Okay, so you can see the results here. So again, we've got about 40% of folks who are at local health departments and another 15 or so, 14% at state health departments. A larger percent of folks from nonprofits on this webinar, about 22%, 9% from universities, and a few from other places. And then we've got 71% of folks who are just watching by themselves, but we've got another 10% who are in the room with somebody else. So that's all really good to know. Thank you for filling out the poll. Okay, great. So let's move on to the presentations. I'm going to start with a brief overview of the Health Equity Guide. Since we discussed the background of the guide on the first two webinars, I'm just going to do a very brief recap and then talk more about community organizing, about power, and about why it's important to work with community organizers to address equity. First, a tiny bit about Human Impact Partners. We're a national nonprofit that brings the power of public health to campaigns and movements for a just society. We do that through research, capacity building, and advocacy. And on the slide, you can see the issue areas we focus on as well. Through HIP's capacity building work with health departments, we saw that the field could benefit from a resource that highlighted effective practices to advance health equity, and from concrete examples of how that work was being accomplished. You can find more background about the site, including how it was developed and who was involved in developing it, on the About page of the website. Let me just say that the theory of change that underlies the site is that the causes of health inequities are power imbalances and racism and other forms of oppression. So to truly advance equity, health departments must focus on power and on oppression. To do that, they need to use an inside-outside strategy. On the inside, they need to make internal changes, like training staff, changing hiring practices, and using data and research very differently. But that alone won't be enough. They also need to partner with other government agencies to advance equity, and the subject of today's webinar, work with community organizing groups as well. That's the core of this outside strategy. So today we're going to focus on fostering community partnerships. On the left of the slide, you can see the various strategic practices within the Health Equity Guide organized by this inside-outside approach. Within the fostering community partnerships category, there are 3 strategic practices: build strategic community relationships, share power in decision-making, and spark meaningful participation; build alliances with community partners to protect against risk and build community power; and engage strategically in social justice campaigns and movements to advance equity. Our Alameda, Kansas City, and NACCHO presenters will each describe how they advance one or more of these practices. And then after the webinar, we encourage you to dive into the Health Equity Guide to read more details about the case studies you'll hear about the strategic practices we'll talk about, and actions you can take to start moving them forward, and about other resources that can help you get going. So let me say a little bit more about why we focus on power. Health inequities result from inequities in the social determinants of health. Inequities in the social determinants of health, like housing and employment conditions, exist because there is an unequal distribution of power in our society. Those in power benefit from the inequities and the status quo. They push back against policy change that would address inequities because those changes hurt them, usually financially. Those facing inequities, on the other hand, usually have experienced decades or centuries of disenfranchisement and a lack of power relative to those who control our institutions. We also know that those who have power use forms of oppression, like racism, to maintain that power. This all means that to address inequity in a lasting way, we in public health need to address power imbalances and confront oppression directly. If we do that, if we make our systems and institutions accountable to all people, we'll see equity in the social determinants of health and then health equity. So then the question is, how do we in public health take on power imbalances? We believe that local health departments need to work with community organizing groups to build power on the outside, because very practically, public health agencies by themselves do not and will not have the power to make change on their own. So before going further, let me define what I mean by community organizing. We do not mean just any community organization that's based in the community. Our definition, which is based on the work of Mary Minkler, is that a community organizing group brings people who identify as being part of a community together to solve problems that they themselves identify, helps a community mobilize resources and develop and implement strategies to reach their collective goals, and works to develop civic agency so that people can take control over their lives and environments. Others may use the terms like grassroots organizations or base building organizations in the same way we use community organizing. So why work with community organizers? As I said, public health agencies themselves don't have the power to make the changes necessary to significantly advance equity on their own. Community organizing groups tend to focus their advocacy work on improving the social, economic, and environmental determinants of health, even if they don't think about it that way or use those words. So their work may align and complement the work that local health departments are doing or are wanting to do to address inequities. Many of us also believe that to be most effective and long-lasting, the people most impacted by issues should be at the center of making change. Community organizing groups work with the people most impacted by inequity. And last, a core component of community organizing is building the leadership, agency, and power of community members suffering from inequities. Community organizers can bring both relationships to community members and other community organizations and institutions, and an understanding of those communities to the work you at a local health department are doing. So that summarizes what we're advocating for when we talk about local health departments fostering community partnerships to advance equity. So with that as background, I'm excited to dive into our two case studies. First up, we have Sandy Galvez, who is the Director of Health Equity, Policy, and Planning of the Alameda County Public Health Department and former Director of BARHI, the Bay Area Regional Health Inequities Initiative. She currently serves on the State of California's Office of Health Equity Advisory Committee and has also served on NACCHO's Health Equity and Social Justice Committee, the Bay Area's Metropolitan Transportation Commission Policy Advisory Committee, and as a Planning Commissioner in the City of Oakland. Welcome, Sandy.
Thank you, Jonathan, and good morning, everyone. So, if Jonathan didn't say, we have 5 minutes each, so I'm going to plow through my presentation here. Our first slide is really focused on some of the key tips that we have and how to work with what we've done to work with community as being real partners. First of all, we started by conducting data analysis that's useful for the community. You know, for a long time, of course, we've been doing health status reports and sharing health data at large for our community. But beginning in the early 1990s, we really started highlighting social issues and the connection between those social issues and health problems. And that really spoke to the lived experiences of people in our community. And so that made the community see us as a resource for them. Related to that, we use that data to share it broadly, to share it with academics, with organizations, with institutions, with the media, and with the community to really change the public narrative around what drives health outcomes, to really that it really wasn't just about genetics, healthcare access, and people's behaviors, that it had much more to do with the social opportunities, the environmental opportunities, the economic opportunities that people have, and that if we wanted to impact health outcomes, we needed to impact those things. Related to that, we spent a lot of time getting to know who were all the players in our community, not just the traditional partners we've had in terms of other healthcare providers, but really the organizations and the groups that exist to organize people and to advocate for progressive change, as Jonathan spoke about. And we invested a lot of time in just getting to know those groups and coming at them with how can we partner with you to make an impact on these social problems. As that work grew, and I'll be speaking a bit more about our work in Place Matters, we started an initiative. We started putting it together in 2006, and by 2010 we developed a set of work groups with community partners to address 6 different social areas: land use, transportation, education, economic development, criminal justice, and housing. And we've worked together for many years on developing different campaigns to address policy wins around those different areas. And then related to that, in terms of being involved in policy work, it's really using your lane effectively. We're not advocates. We're not community folks. We're the public health department. And so our role is really about bringing that expertise, that respectability that a public health department can have, and sharing that, the scientific connection between health outcomes and all these different social indicators. And then lastly, I use the term continuous quality and outcome improvement, but it's really working with our partners continuously to talk about what could we do, how could we do this work better, how are we doing, what's working well, and how could we improve. So that's been a real part of just the way we do our work. We started doing our work around advancing inequities, honestly, because we saw we had inequities. Many of you have probably seen this, but in our county, if you look at a white child born in the affluent Oakland Hills and compare it to an African American child born in East Oakland, which is not very far away, as an infant, that child will be almost 3 times more likely to be born low birth weight and 10 times less likely to have a mother with a college degree. As a child, that child will be 32 times more likely to live in poverty and 3 times less likely to read at grade level. And as an adult, he or she will be 5 times more likely to be unemployed and almost 3 times more likely to die of heart disease. And so these social indicators were things that really weren't within the realm of control of the public health department. And so we really know that in order to address these things, we need to work with others. And so if you look at the cumulative impact of all of these inequities throughout the life course, it comes out to a 14-year difference in life expectancy for white children in the Oakland Hills versus African American children in East Oakland. And so looking back through our work to advance health equity, some of the biggest impacts that we have seen, as I said, is that we've done a lot of work to change the narrative on what impacts health. We've worked a lot with doing a lot of presentations, really trying to just inform the general public and policymakers, decision makers, and institutional leaders on what impacts health. We share that data broadly. We've also done a lot of op-eds, and a lot of our reports and press conferences have received a lot of media coverage, and so that has helped to change the narrative on what impacts health, at least in our community. Through the years, we've become a valued partner by community groups. They really see us now as an automatic and standard partner in areas that we previously were not connected to. So partners understand that we're concerned about how social issues affect health and that we can be an effective partner in helping move a progressive policy agenda forward. We're also now seen as a respected stakeholder in policymaking arenas, so we're often invited to participate in task forces and think tanks and work groups that policymakers establish to come up with different ways of doing things, as well as often asked to give public testimony to informed policy decision-making processes. We've also, in working with our partners, have been involved in a lot of policy wins. In the area of tenant protections, we've helped we've helped pass some rent stabilization and strengthening the just cause eviction ordinances in the city of Oakland. We've also helped inform the county. Our county passed a $500 million housing bond, as well as set aside some monies for $3.5 million for as an anti-displacement fund. And so we've helped inform those decisions and the way that those get implemented, as well as we've been working with a utility reform network in our state to pass legislation to protect vulnerable populations from utility shutoffs. As far as land use, we helped pass the first ever health element that focused on incorporating health and equity into goals and solutions for our unincorporated area in our county. And we've been working with a large group of community partners to develop healthy planning guidelines for the city of Oakland. That it's a guidelines that would be used to review new development plans in the city of Oakland with a health equity lens. And we've also, those are some of the more proactive things we've done for land use. Also, we've been involved in several important land use decisions where we raise the needs of low-income communities. One example has been a coal-by-rail process that came to the city of Oakland, where a coal plant wanted to pass coal and ship it overseas through the Port of Oakland. And those trains would run through some of the lowest income communities and most impacted communities as far as asthma in our community. And so we provided a lot of public testimony and health information to affect that decision, which, although it's in court, the city of Oakland did not permit that process to go through. And then as far as education, we've also we've done a health impact assessment to inform equity-based funding for the Oakland Unified School District, as well as partnered with them on diverting kids and families that had previously ended up through a criminal procedure for truancy when what was causing truancy in the first place was health conditions, and now there's a partnership set up where those families now get diverted to our case management programs instead. So those have been some of the impacts, and I'll be happy to speak more about them during the question and answer if anybody has further questions. And so we were asked to share, our thoughts of what is one thing that health departments could do to get this work started. And I think the main takeaways for us is to, like I said, do data analysis if useful, and that speaks to the lived experiences of what normal folks know is driving inequities in their communities. And then just get out there and start getting to know your community without an agenda of, I'm coming to you because I have this program and I want you to participate. But really, it's how can we work together to improve the community? And so that's my quick presentation, and I will now pass it back to Jonathan.
Great. Thank you, Sandy. That's amazing work, and you guys at Alameda County have been an inspiration to so many of us for so long. Thank you very, very much. I'm now happy to introduce Dr. Rex Archer, who is the Director of Health for the City of Kansas City, Missouri. The Kansas City Health Department received FAB accreditation, was a co-recipient of the 2015 Robert Wood Johnson Foundation Culture of Health Prize, and 2016 winner of the NACCHO Local Health Department of the Year Award. Dr. Archer is a past president of NACCHO, an executive committee member of the Public Health Accreditation Board, and has served on numerous national committees. Welcome, Rex.
Well, welcome, Jonathan, and I really appreciate your organization's lead on putting these together. I'm going to basically not try to cover in detail what has been accomplished. That's why you've got your website, and there's an 8-page document that in more detail describes what we've been doing. What I'm going to do is try to convince folks that are on the phone why it's practically public health malpractice to not be working with community organizers. So you'll see with this slide that we talked about an MOU that we actually have with one of our community organizing groups, and we work with a number of them. This one, though, you'll see some of the parts are in that MOU. But what I want to kind of convey to folks is a little bit of a story. So in 2007, and I'll show you a map here of Kansas City on the left there, 320 square miles, 4 different counties. It's actually almost 65 miles from the north end of the county to drive all the way down to the south end of the county. So 2007, Saturday morning, it's not an election year. I'm at a local church way in the south end of the county, and I've got 5 of my 12 council members that are there for 4.5, 5 hours. The fact that a community organizing group could pull 5 elected officials out on a Saturday that's not even an election year and hold their attention for that period of time shows the power and influence that they can have. That caught me, and I thought, boy, I've got to learn more about this. So I became, in a sense, a community organizing intern in 2007. I attended one of their trainings, started getting more involved. We started a courtship that's moved on to an engagement, and you could almost call it a marriage now. And I'm going to move on to the next slide, but I'm just showing some of the data of our 14-year difference in life expectancy and the various challenges we've had. But I've been health director here now for 19.5 years, and until around 2007, we were not making a lot of progress on health equity. Moving to the next slide, what you'll see here is some of the impacts that have occurred. And we actually have this as daily conversations now. We actually have a number of council committees that traditionally we might not have been invited to, but that the city council members actually now call us and ask for data. We've got one actually later this afternoon where we would normally have not been invited, but we've been invited to bring data to that committee. We actually have in our 5-year city business plan now a objective to increase overall life expectancy and reduce the inequities between our zip codes. So it's actually officially in the city's business plan, and the city council has adopted that. We had 70% voter approval of a property tax that's generating an additional $15 million because of that tax a couple of years ago, 3 years ago. So we had very strong support on that. Jonathan already mentioned a number of the awards and recognitions. What we're talking about today has been deemed a model practice by NACCHO, and I really do encourage folks to kind of get engaged with this, learn how to do this kind of work. If you've not seen the Public Health Scenarios 2030, I encourage you to Google that, get the document. There's a nice 46, 48 pages that really go through various kinds of future scenarios. There's videos with it and so forth. But we as a health department and as our health commission actually chose scenario 3 not just as what do we want to prepare for, but what do we want to actually create. And I think this shows that vision of the chief health strategist there in the yellow dress, our data capacity, how we are about facilitating community transformation, how we partner with all these different groups. But you'll notice the top right, those are supporting social movements. And to be honest, that's where most of our benefits have occurred in life expectancy and public health over the last 100 years. You know, it's really social movements that we need to be engaged with and support. And my final kind of comments are, don't go to a partner expecting them first to help you with your priority issues. Instead, listen to their issues and concerns. We frequently, and as part of our accreditation process, when we had our panel in of community members, they were voluntarily saying, hey, you know, this is a group that figures out what data we need when we don't even know to ask for the data and brings it to us to help us with our mission and purpose. Once you've worked with folks, you know, and it's an area where it may not be in our top 10 priorities, but if it's still in our top 50 or 100, it's worth moving forward with, particularly if we then build a partnership where then they're more likely to think about some of our top 10 down the road. So, you know, that's really what it's about, I think, in our community. And with that, I will pass it back to you, Jonathan.
Great. Thank you so much, Rex. That was amazing. You guys are doing great work, and I can't agree with you more about the need to work with community organizers. I love the story about how you got involved and how working first on their priorities may be a good inroad to building that relationship that then allows you to work on your combined priorities. That's a great story.
Yeah, Jonathan,
okay.
Probably one thing I should have mentioned is that our partnership developed to the point where they now rent space in our building and are here so that we bump into each other in the elevator and common rooms and actually share more resources than we would have otherwise. And so if you have opportunities for that in your community, you can't necessarily do that the first year. That may take 10 years, as it did us about 7 to develop that.
Yep. No, that's a great model. I love it. And then they can hold you accountable in that elevator, too, which may be uncomfortable, but it's good for us. All right. So I want to, before moving to our last speaker, to Yvonne, I want to do one more poll, and you'll see it appear on your right. These questions are for everyone who works for or who works with a health department. For those who work in nonprofits or in academia or as consultants, but with a health department, we'd love you to reply based on your assessment of the health department that you work with. So the first question there is that we want you to rate how advanced your health department is with respect to fostering community partnerships in the ways that we just talked about, building relationships with community organizing groups, for example, and working with social justice movements. Where are you in the life course? Are you in infancy, preteen, adult, wise elder? Don't know. And second question there is, of the practices listed, which do you think is most developed at your health department? And again, you've got the 3 strategic practices and then a don't know and not applicable category. So choose the best option for you, and then remember to hit the submit button, and I'll show the results in a minute. Please note, again, that you might need to scroll down to see all the questions and answers. And as we're waiting, I just want to note that we had more folks on today's call than on previous calls from nonprofits. And so, again, and from foundations and hospitals and other organizations. So if you do work at one of those other institutions, please rate how your health department that you partner with is doing. Okay, so if you didn't, please press the submit button. No, it looks like the results are up, which is great. So we've got about 18% are feeling like they're in their infancy, another 36%, so that's actually less than on some of the other strategic practices that we talked about on previous webinars. 36% are in their preteen years, another 15% are adults. So again, we're seeing a little bit more comfort and familiarity with working to foster community relationships than we saw in some of the other strategic practice areas. And then a large majority find that building community alliances is where they are doing their best work, as opposed to sharing power with community organizing groups or engaging in social justice campaigns, which only have a couple % each. So super interesting that that's where folks are feeling like there's energy and movement. So thank you again for filling that out. Okay. So now to wrap up our speakers, I'm honored to introduce our last presenter for today, Yvonne Thomas-Smith. Yvonne is a doctoral candidate and nurse leader with over 26 years of progressive, community, and clinical administrative experience in public health. She is a champion of public health and population-based service excellence. Yvonne serves as the director of the Evanston Health and Human Services Department and is the chair of NACCHO's Health Equity and Social Justice Committee. And we asked Yvonne to briefly introduce NACCHO's equity work, reflect on the case studies we just heard about, and share advice or lessons learned. Welcome, my friend Yvonne.
Thank you, Jonathan. Excited to be here. So a little bit about NACCHO. First of all, NACCHO has a deep commitment to health equity and social justice work, primarily for the leaders of local health departments. And NACCHO produced a national teleconference for local health department leaders in January of 2000, and then the first annual conference theme was health equity in 2001. And that was the birth of the Health Equity and Social Justice Committee. Now, the focus, particularly of the Health Equity and Social Justice Advisory Committee, is directly associated with dismantling structural racism and class oppression. So from our inception, the committee's goals focuses exclusively by strengthening the capacity of our local health departments to confront root causes of health inequity associated with structural racism and class oppression. And so committee members in the past have worked with the California newsreel to disseminate unnatural causes, which many local health departments use. Unnatural causes is inequity making us sick. After deploying those documentaries, it inspired over 150 local health departments across the nation to conduct town hall meetings, to conduct events that actually screened and talked about the documentary. And the ultimate result assisted in building that solidarity across local health departments. And so with great intention, the committee really focus on advancing the public narrative for health equity. By doing this, we amplified a new narrative which subverts the dominant public narratives by reclaiming a social justice-based narrative. And this social justice-based narrative actually instituted building power through partnerships, such as our community organizers and our community stakeholders, as our two previous speakers eloquently demonstrated in their case studies. And so some reflections that I'd like to share on behalf of the case studies that were presented today in regards to fostering community partnerships. What I heard was Alameda County Public Health Department's case study. They really amplified the need to use data to support addressing root causes of inequities, particularly in their housing for African Americans or people of color, and other areas that really were supported through a lens of data. And what I also heard the speaker share, that leaders improved the capacity by incorporating new funding and created a new division to guide the work, which supported their strategic plan. And I think what's important to remember is that the leaders, they also created a space for dialogue, for cross-learning between community partnerships, community organizers, and health department staff, which leveraged and strengthened and made stronger the robust partnerships that they were creating. What I remember in the speaker that shared about Kansas City, Missouri Health Department, they really were intentional about addressing inequities by providing the data, but also understanding that the importance of priority really rested upon those impacted, which were the community members or the community organizers. And this data helped them really reflect and be intentional about how to address life expectancy, which they learned through data was determined by race and zip code. The leaders of that institution also sought intentionally a community organizing partner. And in that relationship that was built in partnership, they created a synergy and shared data and shared power literally by the community organizers and the health officials sharing space. They had a focused alignment, and then power to address root causes of the shorter life expectancies for people of color. And so out of the two case studies, what was resounding for me as I reflected is that sound public health practice really has to meet data with community organizers and a shared lens of focus on addressing those life expectancy concerns. So what I would offer as advice or lessons learned to local health departments or community organizers or those of you who are listening on the phone is that it's important to build trust among the partners, but be patient. Sometimes trust takes time to build, and so being patient allows the opportunity for trust to formulate. And then we must also recognize that we leverage the strengths that we all possess, because we all come to the table with strengths, and we all can contribute, and we must respect that process. But again, we must know that public health can't do this in isolation and cannot do this work alone. And so public health offers this rich data, but community organizers offer the leveraging and contributions of their base or their constituents, and that combination provides a pressure that moves us forward or moves the needle on this great work. We must also not be afraid to self-disclose the barriers that exist in our own and what part we play in the inequities that exist in our communities, and then work with a shared purpose even though approaches are different. And so if we keep those things in mind and work with intention and purpose, which is critical, I think we can really get traction on addressing the inequities that we face. And so now I'll turn it back to Jonathan.
Great. Sorry, I need to unmute. Thank you, Yvonne. That was amazing. I think your reflections are right on, and totally agree. And I think seeing how that played out, how in what you lifted up out of the Alameda and Kansas City case studies makes a lot of sense and gives some clear ideas on how to move forward. So we're getting some questions in. Reminder that we're going to now do about 15 minutes of audience Q&A. And so if you haven't already, you can submit questions or instructions up here on the screen now. And if you and just a reminder, we're going to do 15 minutes now, and then for people who need to leave, they can leave, and then we'll do another 15 minutes after the end of the hour. And if you can't stay on, just remember that the session is being recorded, and you can listen to the discussion later on. So we've got some good questions coming in. The first is that I'll raise up is something that we often hear about, which is how do I make contact with community organizers? We hear that like somebody moving into a community, they're new, they don't know how to reach out, or who's doing community organizing, or their health department has never worked with a community organizing group, or as one question that came in asked, they live in a non-urban health department. How do they find community organizing partners to work with? No, Rex or Sandy or Yvonne, any thoughts?
Well, in many metro areas, this is Rex Archer, in many metro areas, there are community organizing groups that are part of national affiliates. So there's PICO, there's Gamaliel, there's a whole bunch of national community organizing groups, so you can actually Google and try to get a hold of those groups and then see if they have affiliates in your area. Word of mouth is great, getting out there on the street. Anytime there's a policy issue or any movement in your community that may have to do with social justice, there may be labor unions, there may be faith-based community organizing groups that are starting to weigh in on that. So part of it, too, is when you're paying attention to your public meetings and committee meetings and who shows up to testify, and you just kind of start to get to know folks. One of the most foundational things that I learned back 10 years ago was what community organizers call the one-to-one. And that's basically having a one-to-one meeting of getting to know each other on a personal level before you even worry about whether or not you've got a shared agenda and you're trying to accomplish something. So that's some of the ways. Now, in rural communities, that's a little different issue and struggle, and there were some ways I did that when I was in a Appalachian county, but I'd have to think about that question a little more.
Sandy, do you want to pick up on that? I know Alameda County got their hands involved in some community organizing yourselves.
Hi, am I unmuted?
There you go.
Thank you. Sorry, my computer froze, and I was trying to log back in, so I could unmute myself. Well, Rex said a lot of what I would have said. One is to just scope out when there are, policy struggles, when there are campaigns, who's involved, and then start reaching out to the people that you see show up. But I think in a lot of, so I would have said that. The same thing about, a lot of these national organizations have local affiliates, so talking with them. But I think also, if you start attending church services, you start attending just, putting your ear to the ground and finding out what kind of more grassroots things are happening in your community, you're more than likely to start finding people that are movers and shakers in one way or another. And through meeting with them, talking with them, they will also point you to other people that they think you should talk to as well. So I think it is possible. It's certainly harder when there aren't as many established groups, but I think it's still possible.
Okay, great.
Jonathan,
yeah.
If I can add one other caution here, because as we all know, there can be benefits and risks in any endeavor. There are a range of community organizing groups out there. There are those that do what I call a hard pinning versus soft pinning. Hard pinning community organizing groups will sometimes invite elected officials to the meeting. If the elected official doesn't show, they'll put an empty chair up there with their name, and then they'll go after the elected official. So as a governmental agency, you have to stay much more cautiously involved with those that do hard pinning techniques, because that can hurt everything. But there are groups out there that do more soft pinning, where they'll invite elected officials, but they'll tell them ahead of time what the questions are going to be asked, and they'll treat them with respect regardless of what they answer. They won't let the crowd jeer them or that kind of thing. So, be careful that we're being civil and effective in how we're partnering, because there are groups that you've got to be cautious with.
Great.
Let me add one more thing.
No, before you do that, Sandy, let me just say one thing. There was another question that came in. I'll just leave the slide up so people can read it, about what are we defining as a community organizing group. And we covered this a little bit earlier, but I'll just remind folks that it's a group that brings people together who identify the problems that they see themselves in the community, and then figures out ways to they figure out themselves ways to build their power to solve those problems and build civic agency. Go ahead, Sandy. Sorry to cut you off.
Oh, I was going to say, and I think this goes back to my my point about creating data that's useful. When I was at Bar High, I also spent some time trying to identify a lot of community organizing groups around the entire Bay Area region, not just Alameda County. And I found that it was hard. It was hard to get community organizing groups to get back to me, and and eventually I would meet people, but it would be like, oh, that's what you're trying to do, because they didn't see a public health department or public health people as natural allies. And so I think it's important for them to see that there's something that you could actually bring to the table that's in their self-interest too. And so that's why having the data that they could use to help push their own campaigns is important, because you bring something to the table that they could see as being useful to them. And so, I think that was one of the lessons learned for me too, that it's, they don't automatically see us as allies. We're government. They don't, unless they have a pre-existing relationship or some evidence to show that you can be an ally, they're not going to see you as a natural ally.
So those are great answers. Thank you. How about on the inside, Yvonne, let me ask you to answer this first. On the inside, sure. We're getting some questions about how do you start doing community organizing when people or work with community organizing groups when people see that as advocacy. So what do you do in that case? And then a similar kinds of question is, how do you build trust with community organizers if you know that the health department leadership itself isn't really ready for that shared leadership, that shared power model?
Sure. I think if I understand your question correctly, you have to be willing to take risks, but then you have to be honest about your capacity. You know, what can you provide? What can you contribute? And so a lot of that is having a conversation, building an internal relationship, building your power base inside and outside. And so you have to really be open, and sometimes that is taking a risk, and sometimes community organizers can be the adversary or can see you as an adversary when you're connected to a municipality or in government. But you have to be willing to still say, what can I offer? And sometimes you have to be prepared to offer something and not receive it back, or vice versa. And that's what I mean by taking that risk. Did that answer the question, Jonathan?
Yeah, absolutely. And Rex or Sandy, I don't know if you have anything to add as well?
Yeah, I mean, in real estate, it's location, location, location. In public health and power building, it's relationship, relationship, relationship. And, you know, and you develop relationships by connecting with people. You know, we get split a lot. Part of the dominant narrative is fear of the other in this country and kind of separating us. So you've got to find ways to connect to folks at multiple levels, whether that's within your own organization, and sometimes we have as much challenge within our organization of understanding, well, why are you spending all this time with community organizers instead of with me? So you know, there's challenges both ways, but I don't think anybody believes that their health department has the power to fully protect their community and to increase life expectancy and reduce the inequities between zip codes by itself. So without this, we can't get there.
Thank you. So here's maybe a quick question. Have you guys been able to share resources with community groups other than, for example, just gift card incentives? People feel like I'm seeing questions about there's a lot of red tape in providing funding to community groups, and there's opposition to doing that. Have you been able to share resources in that way?
So this is Yvonne. So some of the resources that we provide as government to our nonprofits and our hospitals, we provide public space because we're in a public building. Some of us provide some ancillary clerical support, whether it's helping getting out newsletters, sharing listservs, getting out information. And then literally when we have joint meetings, it's a shared development of the agenda, shared power of presentation. So it's not just government dictating, but actually sharing the power of creating what the agenda looks like, what the conversation and dialogue looks like, and then what are next steps. All of that is done in a shared space, shared leadership. And so it's not government telling community what they need or organizers what I'll give you, but what do you think you need and how can I assist? So it's a really give and take. And again, I really wholeheartedly agree with Rex's comment. It's about relationship. It's about consistency. It's about being available, because everyone is not going to come to your building. You really have to get out in the trenches, get out in the community, not get out to take, but get out to be seen and to be touchable, approachable, and reachable. I think that is critical.
Yeah, so as an example, we get invited to be on a lot of these boards, you know, so to be cross-fertilizing and assisting them. And sometimes we're on that board not just on the public health side, but on the management or the finances or personnel, because we've got experience with a lot of those things to where we can kind of help that agency as a board member. So, you know, it's cross-fertilizing on all these things. We created now is a charter-level health commission as an advisory commission, and the community organizing group that's here in our department, their lead staff person actually chairs that health commission and now comes out with statements and comes out and testifies with our city council on various issues.
Are any of you able to actually contract with these organizations to provide funding for services in other ways as well?
We do have, we have been able to and are starting to be able to more. At least in our community, a lot of the community organizing groups also provide services in addition to doing, activism work. And so we are able to contract with them as we do with any other CBO. And in addition, I mean, obviously they have a lot of expertise in doing leadership development and trainings and convenings and things like that. And so if we're looking to contract for those kinds of things, they're a natural organization to look to be an organization to contract with. So it is possible, and I would reiterate what Rex and Yvonne said about just being able to provide those in-kind resources. I mean, a lot of community organizing work is fly-by-the-seat-of-your-pants work, and a lot of it is voluntary work. And so having, once you have those trusting relationships, because that is key. If you don't have the trusting relationships, they're not going to let you sit at the table and have you be part of everything.
Right.
But once you do, I mean, certainly you can provide a lot of in-kind support. We do a lot of, we help with convenings, we help with facilitation, we provide space, and the different kinds of support that Rex and Amanda have spoken to as well.
And I must say, a lot of this work happens outside of the typical 8:30 to 4:30 or 9 to 5 day. And so you have to be flexible and nimble in terms of time commitment and what you and your staff can contribute, what you can be available for, because, again, it's so important to be present, and that presence, again, may be outside of a 10 a.m. meeting.
That's great. Thank you, Yvonne. Oh, let me throw in one more question before the top of the hour.
Well, if I could just say ditto to those things, but then also say there are times when I'll take a vacation day so I can march with a group, because that's an experience that really makes a difference, and it really cements a relationship when the public health official is out there marching with a group that's concerned about an issue.
That's super powerful. Yeah. Thanks for adding that.
It is.
Let me just add one more question before the top of the hour, which is somebody's asking, how do you basically build internal capacity around this? How do you talk with colleagues who think that they're supporting community organizing, but then in reality they're just working with more standard community-based organizations on issues that are not really fundamentally about changing the balance of power? How do you talk to people internally about organizing?
I think sometimes you have to have those uncomfortable conversations because, again, what I think I heard you say is everyone may not want to participate in righting the power imbalance. And so sometimes you can offer the initiation of those conversations or, assure that there's some education in that they happen, but not doing it, I think, would be harmful to the process.
I think for us, I mean, it's been both, long-standing talking about, in our case study, we talk about our Public Health 101 training series. I mean, we started having conversations with our staff at large, and these were trainings for all of our staff about the root causes of health inequities and what really is driving the inequities we're seeing in our health outcomes. So, we've been talking about this for a long time, like the work to really, just repeating again and again and again in every presentation, every opportunity you have to get the message out about what really is driving inequities, I think helps change the narrative and what people think about when they're thinking about what needs to be done if we're going to do something. But I think, then when we really start talking with staff about what can we do differently, it's really pointing to we're all, I could speak for our health department, we're all working super hard, we're all doing the best we can within the parameters of the programs and services we've always had, and we really don't see a lot of change in the trajectory. We continue to see pretty much the same kind of outcomes again and again, and so, even as hard as we're working and as committed as we are to the families we're working with and the services we're providing, it's not enough. And so, combining the ongoing education with really having a heart-to-heart, it's like, are we really making a difference? And if we're not, what do we need to do differently, and who do we need to be working with to make that difference happen? And so I think, you just need to keep hammering it in. It can't be just a one-time conversation with a few people. It's got to be with everybody all the time.
That is a great thought to close this part of the webinar on, Sandy. What we're doing is not working, so we need to do something different, and I think this is working with community organizers is a different thing to do. So let's close this part of the webinar by, I want to thank our partners on this, the Government Alliance on Race and Equity, NACCHO, the Health Equity and Social Justice Committee, the National Collaborative for Health Equity, and to our funder, the California Endowment, who provided funding both to develop the Health Equity Guide and for this webinar series. And then let me finally say thank you to all of you for joining us today. We've got a few next steps for you. There's one more webinar in this series, the last one, the fourth one. We'll hear from folks in Omaha, Nebraska, and in Minnesota about their work to champion transformative change. So please sign up for that. Please note that if you have signed up for this one, each one is individual. So if you've signed up for this one, it doesn't mean that you're going to be signed up for the next one automatically. So please do sign up. We're going to send you a 3-minute evaluation to complete. Please take those 3 minutes to complete it so that we can make adjustments for the future. Be on the lookout for that, and then also for slides and the recording as well. And finally, we hope that you dive into the Health Equity Guide and find that it's a resource for your work. And we'd love to get any feedback about the site and how we can make it more useful for you as well. So thanks, everybody, for joining us, and hope to reconnect in February. And for those who can, stick around for another 15 minutes, and we've got some more questions for the panelists. But for anybody who needs to log off, we'll say goodbye for now. So go ahead and do that. And then for people who are sticking around, if your question hasn't been answered already, feel free to resubmit it, and we'll know that you're still on the line. But I know that we've gotten a bunch of questions here, and I don't know that we're going to be able to get to all of them. But let's dive into some additional questions now. There's some specific questions. Rex, somebody asked about the property tax that you mentioned that's dedicated to health equity outcomes.
So the property tax is technically not dedicated to health equity outcomes per se. We have a health levy and a tradition of a health levy, a property tax in Kansas City since at least 1955, and we doubled it back in 1989, and then when I came back to Kansas City about 20 years ago, I realized we were capped by the state at not going above 50 mil, and each mil right now, based on our property tax, generates about $700,000, just to kind of put that in perspective. So we went, luckily, and got that cap raised to $1. We then, in 2004-05, felt that we needed additional money in health levy. We fund some of our federal qualified health centers. We fund some ambulance service. We also fund quite a bit of our health department out of that health levy. And we went to the voters for a 9-year 22 mil, which generates about $15 million. That was approved, but maybe only by about 55% or so, if I remember correctly. But our continued work with our various community organizer groups and safety net providers that we fund and others, when that came up for renewal after that 9-year period, we had a 70% voter approval. So, but we use those dollars to fund, we have 3 full-time public health statisticians just to be able to help us in providing data when different community organizing groups that are out there, or even not-for-profits that don't see themselves primarily as a community organizing group, but they do health-related services, we help them in getting grants by providing them with data so that they can more adequately compete for dollars because they have the data. Great.
Thanks, Rex. And Sandy, a specific question for you. Has there been any coordination and inclusion in Alameda with the American Indian Health Boards or the Urban Indian Health Care Advocates? You may be on mute.
Thank you. I once again got locked out of my computer. Not within our Place Matters work specifically. It's possible that some of our programs and services do work with our Indian health boards, but not our policy and systems change work has not worked with them. We're working mostly with community organizing groups that see our work groups that we have around our different areas and help inform the priorities that we work on, as well as the campaign.
Okay, thank you. All right, so here's a relatively tough question. Our health department sometimes gets pressure from our elected officials to not favor community organizers over industry. Can you give an example of how a local health department worked with industry and community organizers when these two camps didn't agree on policy change?
Well, do you want me to go ahead, Rex?
Go ahead.
We don't. By industry, I mean, are you meaning businesses? I mean, do you think that's what? Because we don't.
Yeah, I think businesses. Yeah.
Yeah, and we don't do a lot of work with businesses. So maybe if you have examples of that, I do have examples where we've been able to bridge partnerships between policymakers and government agencies and community organizing groups through our work, but not business. So Rex, if you have a more business-oriented example, that would be helpful.
Yeah, we work with everybody if we can, and yes, occasionally on a specific issue, the business community may not be in the same place that the community organizing grassroots are. However, what we have found is sometimes with the right education and enlightenment, we may move the business community from opposing an issue to going neutral. In some cases, they actually take the lead. And Tobacco 21 is a good example where we actually got the chamber to take the lead and do all the real politics and the heavy lifting to get that passed. And we've also had times when we've worked on a living wage increase where the business community decided to not oppose it. There might have been certain individual business owners that opposed it, but that the collective group didn't oppose it. So, yeah, it is an interesting issue, but it depends on what it is. We're working on housing issues right now, and the quote, slum landlords will oppose some of the things we want to do. But it turns out that most landlords that actually care about it and don't want these ones that are giving them a bad name or creating some of the eviction problems or other stuff that's going on across the street from them actually do want regulation. So sometimes it takes a little bit longer. One of my favorite sayings is out of Peter Senge's concepts on systems thinking. Sometimes faster is slower. Sometimes you do have to kind of slow it down a little bit, regroup, not give up, but lay the groundwork with another group, and maybe the most you'll get is them to go neutral.
So we're getting a few different questions that are kind of along these similar lines about people with different values. So an example of, let me read a couple of these questions. In a rural community that tends to hold conservative values, how do you approach potential partners who don't hold similar values? And then somewhat similarly, you must have had some conservative political pushback, for example, Rex, for your MOU with community organizers. How do you sell that to get elected officials to sign off on it?
That's a great question.
Well, I mean, if I had done that, probably, not that I was even wise enough to see the advantages the first or second year that I was here, who knows what would have happened. But, our relationship had continued to grow and develop. I didn't mention that this community organizing group had, when our elected officials had just come into office, and they had organized an event at our Union Station and literally had over 1,000 members of their congregation sitting out in the audience, and then the procession occurred with the 102 clergy, or rabbis and Catholic priests and Baptist ministers and Unitarian Universalists and Eastern Orthodox. All those folks marched down and took up the first 3 rows, and all of the elected officials were up at the front. And so, you know, they saw the power, in a sense, but also the concern and compassion that the audience had on these issues. And so I actually didn't get a single question from an elected official when I moved them into our building.
That's amazing. It's amazing. And so, and what about this question about, for maybe Yvonne, what about approaching someone who has different values? How do you start talking about this stuff with them?
Sure. So I wanted to kind of offer an extension of the example that Rex gave with the Tobacco 21. We in public health, of course, had data around how many youth in our community were smoking, when they first started smoking, and how, you know, industry used the youth movement or youth as targets to be the new replacement for the older populations that were dying from various cancers related directly to smoking. And so at the same time, we kind of used that space to prohibit e-cigarettes in the same way. So we had some groups saying that e-cigarettes was helpful in smoking cessation, so why would you prohibit it the same way as cigarettes? It's not the same. And we had small grassroots various groups storm our city council chambers to kind of resist this Tobacco 21, but it was a student group who called themselves the replacement targets, really amplified the need to raise Tobacco 21, to prohibit not only the purchase of cigarettes or tobacco products, but also the selling of tobacco products, just like we prohibit the same way for alcohol. And it did pass, and, you know, it was some contention, some resistance, and some of the resistance was silent because there were letters to the elected officials and letters to the mayor because some people did not want to be on live stream in opposition. But still, in that space, you know, everyone was heard, whether it was supportive or contention. The data still demonstrated and still continues to demonstrate a decrease in the number of youth that are starting to use tobacco products and that are using tobacco products in our jurisdiction. And so Evanston actually was the first community in Illinois to become Tobacco 21, and so now we're trying to use that same process in establishing those ordinances and creating that statewide ban. So again, there was a lot of conversations, there was a lot of behind-the-scenes work in terms of collecting the data, arming our student ambassadors with the information that they needed to carry the message, even in, you know, in the space where there were retail rising up and saying this is going to impact our revenues, et cetera. So that was a great opportunity for us to just kind of push the envelope, even though our business community did not support that initially. But and again, it's been 3 or 4 years, and the data still demonstrates that the number of youth that are smoking in the community continues to decrease every year.
That's a great story, Yvonne.
Jonathan, I did think of another piece that I think needed to caution people about, and I'd mentioned it earlier, but just to reinforce it, I would not have brought a community organizing group into our building that did the hard pin strategies. Mm-hmm. So this group had the relationships with the city council as being respectful. They may disagree and they may come out different than what the council is, but they've always treated them with respect and not created those kinds of issues or problems. And so, yes, there are other community organizing groups that we, you know, work with, that they request assistance from us and we provide them with data and so forth, but we wouldn't have brought them into our building.
Great. Okay. Thanks, Rex. So let me fit in one more question, and that's, and maybe we can just get a quick answer to this, if there is a quick answer. We're getting a few different questions about the role of state health departments, and so can state health departments work with community organizing groups is one theme of questions, and then another is what support have you received from a state health department for these local initiatives? What can a state health department do best to support and encourage local health departments to foster partnerships with their communities in the ways you're talking about? Any quick answers to that?
I think for me, the thing where I've always felt that the state health department, because the state health department, at least in California, is a lot of funder for a lot of our services and programs. And we've done a lot of work through BARHI, through NACCHO, and other organizations to try to make sure that any restrictions in funding that don't need to be there aren't there. Because oftentimes that's where the biggest problem is that the funding restrictions limit who you can work with and on what. And whenever those restrictions can be lifted, I think that creates that opportunity then for local health departments to be able to work out of the box a little bit more than they would otherwise.
Great, thanks, Sandy. And Rex, were you going to jump in too?
Well, Missouri is 50th in funding for a local health department, so it's been a little bit of a challenge in regards to funding. We get 28 cents per person per year, basically, from the state if it's not a pass-through grant from some other resource. I think the bigger problem that we have in Missouri, and where state health departments could be more helpful in a sense, although it's not easy in certain states, the biggest threat to public health in our country is preemption at the state level, where various kinds of policies that could produce health equity are stymied or reversed. We've passed living wage one time with 70% voter approval, basically, and then the state overruled that and doesn't allow us to move forward. So that's probably the bigger issue is, in some ways, the state legislature in some states is more dangerous for the public's health than any other body, and actually our chamber is much more progressive than the state legislature is by far.
Yep. Another thing that the community groups can offer, right, which is many of them actually work on voting issues and can help change that legislature. So
correct.
Right. Yvonne, were you going to add one last thing?
Yeah, just one last thing. I want to end on a positive note. I'm in the state of Illinois, and we did not have a state budget for 2 years. And so our challenge was understanding that we could not rely on that direct funding and really think out of the box and collaboratively with our local partners was really critical for sustainability in the work.
Great. Thank you, Yvonne. All right, so I think that means we're out of time. So thank you, everybody. We still have over 280 folks still on the line, so thanks for staying on and having more questions for us and listening to the answers. As I mentioned, we have one more webinar coming up. We have the evaluation, and we encourage you to dive into the website itself, healthequityguide.org. And at the end of this whole process, we're going to compile a list of top 10 questions and post them up on the website as well. So that's the end of today's webinar. Thank you so much again for sticking with us, and hopefully it was useful for you. Looking forward to talking to you next month.